Good. Okay, so mild penicillin allergy. Okay, so more potentially giving penicillin. So if we come on to the answers, so you could, as you rightly say, actually try them with some Fluclox or Augmentin, so penicillin-based antibiotic if you felt that was appropriate. Potentially giving the first dose in A&E and observing them. Cephaloxin has the same sort of side chain as penicillin, so although it's a cephalosporin, actually essentially comes in the same sort of penicillin allergy risk as Fluclox and Augmentin, unlike, for example, ceftriaxone, which is you would potentially give to someone even if you thought they were mildly penicillin allergic. What often happens though is they get given something else, and a macrolide, certainly in primary care, would be a common choice. You could still go for your topical fusidin. Okay, what if they are severely allergic to penicillin? So they've had anaphylaxis, they've already seen the allergist who says this is definitely penicillin allergy, do not take penicillin. What else could you give? So macrolide, obviously I've already given you that one, but is there anything else that you could potentially give them? Okay, so you could give a third generation cephalosporin. So if you're giving IV, that's pretty straightforward. There's not that many that are oral though. Anything oral, so if this is a kiddie who either is in GP, in primary care, or somebody's come to A&E and it's sort of fairly crusty around their mouth, but they certainly don't need hospital admission. Okay, lots and lots of people saying clindamycin, excellent. Get it to roll on. So top of the list, clindamycin. Then there's a whole list of other things potentially you could use. Macrolides, potentially, obviously, ciprofloxacin, cotrimoxazole is pretty good, and then some other things that doxycycline you probably wouldn't use for a child. Rifampicin is a good anti-staph agent, but generally not good to use by itself because you get resistance pretty quickly. Linezolid, you kind of usually saving that for the very unusual cases. Okay, what about if it was MRSA? Would you do anything differently? Okay, so vancomycin is you kind of go to antibiotic for MRSA. Downside with that, if you want to send the child home, vancomycin you're going to be giving IV, aren't you? So it's difficult to give oral. So linezolid, a couple of people said, yeah, you can just go for clindamycin. So the vast majority of MRSA strains will be sensitive to clindamycin. Actually, most of the time, clindamycin is fine. The other very good one is cotrimoxazole. So Septrin is another good antibiotic for MRSA, which has lots of safety profiles. So either of those two probably would be my first choice. Clearly, you can use linezolid if it was a short course. There are side effects if you use it longer term, but for a short course of this, you potentially could do. But I'd certainly use the other two ahead of that. Or you could do something topical. Again, mupirocin, that's what you use for kiddies with sort of recurrent MRSA as a sort of decontamination up the nose. So potentially, if it was relatively mild, you may be able to get away with just topical mupirocin. Good. Okay. So that's enough about sort of staph and impetigo. This is more your kind of pediatric on the ward. So you've got a 5-year-old child, previously fit and well. They develop pneumonia, but they're kind of systemically pretty well. They've developed received amoxicillin, and somebody very diligently sent off a throat swab or a cough swab, and it's come back positive for mycoplasma. So which of these antibiotics would treat mycoplasma? We can have a whole other discussion about whether you'd want to treat it or not, but just for the purposes of this, what antibiotic would treat mycoplasma? Or which of those would treat? You can just type in the numbers if it's easier. Okay, so 1 and 2. So macrolides, yeah, is the right answer. People have gone 1 and 2, azithromycin. Somebody said all of them, azithromycin. Okay, so those 3, 1, 2, and 4 are the macrolides. Clindamycin, despite lots of people thinking it should do, and despite it ending in mycin, actually does not treat mycoplasma. Does anyone know what fidaxomicin is used to treat? And I'll tell you, vancomycin has absolutely zero coverage against mycoplasma. Anyone know anything about fidaxomicin? So that is an antibiotic that is used for C. diff, predominantly in the adult world, but very occasionally we use it in pediatrics. So again, ends in omycin, but is no use for mycoplasma. So it's just the macrolides on this slide, azithro, clarithro, and erythro. Okay, so another 5-year-old, this time a little boy. He's systemically pretty well, but for some reason needs to give an IV antibiotics for a clinical syndrome. But as is often the case in pediatrics, it's 3 in the morning, you can't get a cannula in. So you think, well, okay, I want to give him something orally then. We'll just tide him over to the morning when somebody else comes in, we can have another go. So any antibiotics that have a very high, and by that I mean more than 90% oral bioavailability. So that means these are antibiotics that essentially you should always give orally, unless there is some explicit reason why you can't. For example, they're not absorbing because they've got some significant GI problem or something. So, a whole slew of co-amoxiclav, okay. I think someone said Fluclox as well. Clarithromycin, okay. So none of those so far. They've all got decent bioavailability, but really, if you really wanted to get high doses, you give it intravenously. So here we go. Clindamycin, yep, excellent. Metronidazole, yep, very good. What appears to be the whole of Barnet General Paediatric Department has gone with ciprofloxacin, yep. And the whole of the neonatal, I don't know where, W Northwest somewhere. Levo, so yeah, so that's the fluoroquinolones. Good, okay. So we've got a list on there: clindamycin, cipro, metronidazole, cotrimoxazole, cetrin, rifampicin, linezolid. So these are, and there are a few other antimicrobials you could put on that list. Voriconazole is one that we use quite a bit in the oncology patients. So these are antibiotics that essentially you should more or less always give orally, unless there is some contraindication to giving oral medicine. So as I said before, if you're really not absorbing it for the gut, but otherwise these are, for all intents and purposes, just as good oral as IV. Okay, so this is a real case. 7-year-old with a scalp abscess, known to have MRSA. They'd been admitted because they had a bit of a fever and they were waiting for an IND. They'd been advised to give some vancomycin, and the person who was trying to get a cannula in struggled and couldn't do it, and so they gave them a dose of oral vancomycin to tide them over until someone in the morning could get a cannula in. Is this the right thing to do, wrong thing to do? Can you explain why? It stems a bit from our last question. What's the bioavailability of oral vancomycin? Yeah, so we've got excellent. Couple of wrong, and vancomycin is poorly absorbed by GI, it's only used for C. diff. Perfect. So bioavailability of vanc is essentially 0, so it's very good for treating gut issues like C. diff, but absolutely none of it is absorbed. So actually this kid got a dose of oral vancomycin essentially inappropriately because it did absolutely nothing for his MRSA scalp abscess. Okay, so this is partly covered already. Big list here. Which antibiotics are good to treat MRSA? And so here we're not limited by the fact that we've only picked oral things. So the kid with a scalp abscess, if you really needed to give him something IV, which of this lot would be good? So in vancomycin, you're all going to say, because that's pretty the obvious one. So if there was some reason you couldn't give vancomycin, so for example, I know allergy of some description, really bad red man syndrome, any of the others that you know that are good, some of which we've already mentioned. Yeah, so linezolid. Oh, very good. I have to look through 7. So meropenem. linezolid, ticlinderceptrin. Okay, so meropenem, despite everybody saying it's domestos and treats absolutely everything, doesn't actually treat MRSA. Ones listed there in green do. So most of those you've probably heard of. Ceftaroline is a 5th generation antibiotic. Fifth generation cephalosporin that's very rarely used in the UK. Vancomycin, you probably will have heard of. Again, not very commonly used in pediatrics, is used a bit more in adults. Most of the others we actually discussed earlier. So piperacillin is very similar to vancomycin, obviously. Clinderceptrin, rifampicin, and linezolid. Okay, so something slightly different. So another real case, 14-year-old with a right tibial osteomyelitis. Was initially given some oral flucloxacillin, but then switched to IV ceftriaxone. It wasn't really getting better, so he had a biopsy, and it came back with Enterococcus faecalis. What would you do with the antibiotic in this scenario? Are we happy leaving him on ceftriaxone? Do you want to change it? And if you do want to change it, what would you change it to? So which of the antibiotics listed here are any good for Enterococcus?
Flucloxacillin.
Sorry, I didn't quite catch that.
Flucloxacillin.
Flucloxacillin. Okay. Any other takers? So somebody's gone for meropenem. Okay. So is it going to work? Okay. So Fluclox actually doesn't cover Enterococcus. So amoxicillin is generally the go-to antibiotic for Enterococcus. Augmentin also will do, but essentially because it contains amoxicillin, so the clavulanic acid bit doesn't really do anything. So really, there's not a lot of point giving augmentin. You might just give amoxicillin. Linezolid is pretty good for all gram positive, so that'd be fine. Tyke and Vanc generally are okay, unless of course you've got a VRE, in which case you usually give linezolid. Meropenem and Pip/Taz generally will do. It does depend what sort of Enterococcus. So if it's an Enterococcus faecalis, they probably will treat it. If it's an Enterococcus faecium, they're probably less likely to, and that's the one where actually amoxicillin really doesn't work either. You need to use vancomycin or ticaplanin. So if you in this scenario, you would probably go with amoxicillin. If you found an Enterococcus in a child with perforated appendix and the pus you get out of it has got Enterococcus and they're on Pip/Taz because they're a high-risk patient, I probably wouldn't add in amoxicillin. You'd probably just leave them on the Pip/Taz because probably the Pip/Taz will be treating that. Plus, it's probably like to be a pathogenic or multi-organism kind of problem. So it depends a little bit. In this scenario, you probably want to go for the antibiotic that's got the best activity, and in this case, it's highly likely to be amoxicillin. Ones with gram-negative cover. So I don't quite get that. What would you give for penicillin allergy? So you could either give vancomycin or ticaplanin or oral linezolid. Okay, right, moving on. So 3-year-old, fit and well, fully immunised, fever, cough, crackly sounding chest on the right side. You do a chest x-ray and you show right-sided empyema, and this is in non-COVID times. And your pleural fluid grows strep pneumoniae, which is fully sensitive and actually gets better pretty quickly after the drain and a course of antibiotics. Would you have any concerns about immunodeficiency? So otherwise, well, fully immunised kiddie gets better fairly quickly, but with a fairly significant sounding right-sided empyema. Concerns about immunodeficiency? So I think someone said yes, potentially. Anyone going with no? Oh, good. Okay, so lots of yeses, nos, maybes, depends if first infection, not necessarily, only if recurrent, probably not as isolated. Okay, good. So what if I told you it was one of them that's not in the vaccine? That change anybody's mind? Probably anyone who wasn't too worried before. If it's one that's not covered by the vaccine, that's probably less. It's not probably not going to change your mind. What if I tell you, well, maybe it was a vaccine? It was one that was in the vaccine, and they had the vaccine appropriately. Does that make you more concerned, less concerned? Yeah, okay, so it might make you more concerned, depends have they seroconverted, depends when they had their vaccine, depends what the levels are like, depends what the actual serotype is. There are some that are more sort of sensitive than others, okay? Any difference if it's a 1-year-old or a 14-year-old? Somebody actually said you might want to look at the vaccine responses, yeah. That's reasonable, although of course now they've had that, it will make it a little bit more complicated to know what, if you find a high level of antibody for that one, what that means. People more worried if it's a little baby versus an older kiddie. Maybe more worrying the younger kid, okay. And if you found it, instead of finding it in pleural fluid, if you found it in blood, throat swab, joint, or pneumococcal antigen in this 3-year-old, would that make you any more or less worried? So if we say about in blood, okay. So if you find it in blood or joints, found it at the same time, then obviously yes, that would be very worrying. If you found a kiddie with sort of a septic arthritis, let's say, with strep pneumo, does that make you more or less worried about an immunodeficiency, or a blood bacteremia with strep pneumo? So I mean, blood and joint obviously are invasive. Throat swab, lots of kids have that as carriage. So if you just find strep pneumo on a throat swab, I certainly wouldn't be worried about underlying immunodeficiency. If you find it on blood or joint, it may put you into the sort of same category of invasive disease. What about urinary pneumococcal antigen in a 3-year-old? What does that mean? Is that indicative of invasive disease? Yeah, very good. So in little kids, because they've got so much carriage of strep pneumo, you quite often find the antigen in the urine just from carriage. So it doesn't mean they've necessarily got disease. They're certainly under 3-year-olds, possibly even a bit older sometimes. Finding pneumococcal antigen doesn't really mean anything. So whilst the adults use it quite a lot, in little kids, it's not a very useful test. Okay, so this was so just to sort of preface this, the NICE guideline says you don't need to test for underlying immunodeficiency for sort of severe disease with meningococcal disease or pneumococcal disease. Or this is for meningitis. So probably with just a one-off episode, most people wouldn't investigate very heavily for underlying immunodeficiency. Clearly, if there were other risk factors, as someone mentioned, if there was failure to thrive, if it was disseminated disease, it was very atypical, then one might go hunting for it, or if it was recurrent, certainly. I mean, interesting, this article from a big French group found that they investigated all cases, which was about 150 or something, cases of children with invasive pneumococcal disease. So that was meningitis, pneumonia, bone and joint infections, and the like. And when they invested very extensively, they found that a quarter of cases had some degree of underlying immunodeficiency, majority of which were older children, so those over 2. So presumably those under 2 are a bit less likely to have an underlying immune deficiency, probably because young age in itself is a sort of risk factor for more severe disease, probably from a very simplistically putting it, partly underdeveloped immune system rather than there being a sort of immunodeficiency per se. So there's a list of investigations potentially that you might do if you're looking for an underlying immunodeficiency in kids with invasive pneumococcal disease. It certainly isn't an exhaustive list, but this was a list that was put together in Oxford, so they investigated some of their cases. So immunoglobulins, lymphocyte subsets, complement obviously is a potential risk factor. So you can look at the vaccine responses, as somebody mentioned. You can look at CD62 ligand shedding. That's a very niche kind of test looking at one of the TLRs. How jolly bodies and looking for sort of functional hypersplenism, although that's not a great test. And obviously you can check whether or not the child actually has a spleen, because if they don't have a spleen, that obviously is a risk factor. So probably in this case I talked about 5-year-old otherwise fit and well, who recovered quickly, you probably wouldn't go looking for an underlying immunodeficiency, but certainly other cases or recurrent disease, then you certainly would do. Okay, so that leads sort of quite nicely onto this. So a 10-year-old who's on penicillin prophylaxis for asplenia. They developed impetigo around the mouth, and you prescribed them some flucloxacillin because you're worried about staph, and penicillin is not very good for staph. What do you tell them about the penicillin? Do they need to continue taking penicillin whilst they're on the flucloxacillin, or can they just stop? It's a question that comes up a fair bit. Okay, so a couple of people going for keep the penicillin going. Does anyone want to explain why they would do that? Okay, so someone said fluclox won't cover pneumococcus. Yeah, so encapsulated organisms, so particularly meningococcus, fluclox is not really very good at. Do you think stopping it for 7 days is going to make any difference? Just to play devil's advocate. If they've got impetigo and you stopped it for the 7 days they were on it, how likely are they to pick up invasive meningococcal disease or pneumococcal disease in those 7 days? Versus taking 2 antibiotics that are fairly similar, might give you twice as many side effects. Yeah, so someone's put probably won't make any difference as it's prophylactic, but not sure anyone would want to take that risk. Yeah, I mean the risk inherently would be very small if you stopped it for a handful of days, and certainly if there are plenty of kids with asplenia who don't take their prophylaxis for much longer than a handful of days. Usually what we advise is they just continue taking it. It's a daily medicine that they take. If they were on an anti-epileptic, you wouldn't stop them taking that. So it's easy just to say, just continue taking it. In terms of side effects, if they've been taking it for years anyway, it's probably not going to make any difference. Fluclox, as people mentioned, is not very good for encapsulated organisms. So technically they would be at a slightly higher risk, but obviously the risk is going to be fairly minimal if we're only talking a handful of days. So usually we advise just continuing your Pen-V and take your Fluclox on top of it. Okay, what about if they were on azithromycin prophylaxis? Would that change anything you did? Still advise giving both? Would you stop the azithromycin? It probably inherently is the same thing, isn't it? You just say keep going with the azithromycin. One thing you might question is, well, azithromycin actually is your second choice go-to drug for impetigo. So why have they got impetigo on azithromycin prophylaxis? So that may either raise some alarm bells, either the child's not taking their prophylaxis, or is there something else going on? But inherently otherwise, I'd suggest you just keep taking the azithromycin, particularly as the azithromycin usually is only taken 3 times a week or every other week. So, I mean, the reason they've got it might be just that it's a relatively, sort of low level of the antibiotic. Okay, something completely different. It's a case from Oxford, unsurprisingly. 12-year-old, fit and well, walking in a field in Oxfordshire in the summer. And that evening they got home and noticed a tick on the side of their chest. Mum, being very diligent, Googled how you take the tick out, and found you do it with some tweezers. You kind of get right hold of it as far down as you can to the head and yank the whole thing out so you don't just leave the head behind. And pretty confident you remove the entire tick. And there's a bit of erythema around it, and they bring her to the GP, and the GP asks you, so there's a bit of erythema around the bite, which overnight has got a little bit bigger, and the GP wants to know, do you need to treat this child for Lyme disease? Yes, no? Anyone want to treat this kid for Lyme disease? So we've got yes, 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 not an endemic area, I would, unlikely tick only on for a few hours, not yet, wait for some symptoms. Yeah, okay, so there's a fair bit of Lyme in and around Oxfordshire. It's not the most high risk region in the country, but certainly we did see a fair bit of it. What's the most likely cause of the erythema around the bite is probably just the reaction to being bitten by something, much like if you're bitten by a mosquito, you get redness around it, but it doesn't mean you've got Lyme disease. The fact it's enlarged a little bit, well, obviously that depends. If it's suddenly taken up their whole arm, you might consider things differently to if it's gone from 1/2 centimetre to 3/4 centimetre. It's a very short time frame to develop Lyme disease, 12 hours. There is talk that usually the tick needs to be on for 24 hours to be able to do its stuff. Having said that, most kids and adults that get Lyme disease don't even know they've ever had a tick on them. So probably at this stage, I wouldn't treat for Lyme disease. As someone says, it's probably a local reaction. What about if they'd noted the tick only 2 days later? So it was on their back or something, and it was only when somebody noticed them getting changed or something, parents noticed them getting changed. If you noted it 2 days later and there was erythema, would that change your mind? So I think some people still might wait and see what else happens, still probably wouldn't treat at this stage. That's probably fair enough. Depends a little bit, doesn't it, on what their rash looks like. So if they had a rash that looked like that, with a tick that had been on for 2 days, yeah, treat in capital letters. Very good. Yeah, so I think everyone's going to treat that. What's this called? What's the name of the rash? Yeah, okay. Erythema migrans. Perfect. That's the very stereotypical rash you get in Lyme disease. So kind of bullseye, target lesion. And yeah, so the NICE guidance that came out last year at some point would suggest if you see that rash, you treat that as Lyme disease. You don't do any testing for it. You treat for 21 days. Which antibiotic you use depends a bit on the age of the child. So the younger ones you give amoxicillin, the older ones, or teenagers, you give doxycycline, and then there are some alternatives, it's worth looking at that, the NICE guideline, certainly the sort of table of treatment options and the sort of guidance pathway, the sort of investigation pathway. Somebody said it usually appears a week later. That in the context of how quickly does the rash appear after being bitten? Yeah, so it'd be unusual that it would appear like that 24 hours after being bitten, or 2 days, usually a little bit later. As I said, most or up to about 50%, I think it is, of people that get Lyme disease actually have no history of a tick bite that they're aware of. Okay, so again, something different. 8-year-old, previously fit and well. Sorry, somebody's asked, what is the rationale not to test to confirm? So essentially testing for Lyme disease is not brilliant. So it's a serological test, takes several weeks to seroconvert. So if after 4 or 5 days you got that bullseye rash, if you do serology at that point and it's negative, it doesn't really help you. The vast majority of people who have proven Lyme disease at that point would have a negative test. It's only several weeks later that your serological test will turn positive. So actually, for the vast majority of kind of mild cases, you're not going to have a good test that's going to give you the answer in any kind of time frame that's useful. So hence the rationale for treating on clinical suspicion. It gets more complicated for the sort of chronic Lyme ones. You've got all the sort of symptoms of lethargy, and they may have had a rash and they may have had a tick bite, but that's a totally different kind of group of patients. The ones that present with something like just the rash, the only real testing we can do is serology, and obviously it takes a while to take a while to seroconvert. Okay, so 8-year-old, previously fit and well, fever and a large lump on the left elbow with erythema. So this is again a real case. MRI of the elbow shows epitrochlear lymph nodes, and the report from the radiologist says this could be Bartonella. So this is a microbiological diagnosis from a radiologist. Pretty impressive. Do you believe them? Can that be true, or do we think that's true? Bartonella is a cause of big lymph nodes in the elbow. Have they got any cats? They, I believe, did have a cat. So someone said possible epitrochlear, always pathological, long list of differentials. Yeah, sure, obviously. So actually, when we looked in the literature, something like 1 in 3 cases of people with epitrochlear lymph nodes are actually caused by Bartonella. So pretty common cause of epitrochlear lymph nodes. Clearly, there is a whole list of other things it could be, but that's pretty high on the list. How would one test for Bartonella? Any ideas? Ask ID, very good, yeah. Tissue, PCR, yeah, okay, good. PCR serology, yeah. So serology you can do for a while. They stopped doing it at PHE. I think now you actually get sent. I have a feeling it gets sent to France, but I might be wrong. But you can do serology for it, and you can do PCR from tissue, for example, lymph node. Yeah, that's perfectly doable. And actually, in this instance, the child actually did have a lymph node biopsy of that epitrochlear lymph node, which did find Bartonella on PCR. There is a case, was written up as a case report by a colleague, and I think it's somewhere in PIDJ, if anybody wants to dig it out. I think it was published in the last year or two. And how do you treat Bartonella? As in cat scratch Bartonella, hence. Any idea what antibiotic you use? Okay, so someone says azithromycin. Yeah, good. So, I mean, Doxycycline, azithromycin, as people mentioned, yeah, good. I mean, essentially the evidence is pretty scanty. So azithromycin is a good choice, often used with rifampicin. Actually, the list underneath also are actually appropriate. So this kid actually received ceftriaxone quite a while before we got the biopsy result, and actually his lymph node got better. So ceftriaxone is used, penicillin, so amoxicillin is often used, fluoroquinolones, gent. So it really depends sort of how unwell the kiddie is, you know, what the clinical picture is, but any of those are potential options. Okay, so this was another radiological microbiological diagnosis. So 1-year-old fit and well, fever and a large lump in the left side of the neck, and they had an MRI of the neck and chest which showed lots of necrotic lymph nodes and a necrotic thymus. And the radiology report said, could this be mycoplasma? What do you think about that? Almost everything has been associated with mycoplasma, so of course it's hypothetically possible. What do people think? Plausible. So someone said too young. Okay. So if it was a 5-year-old, would be happy with that. Right about TB, could be something oncological. Yeah. Okay. So we looked that up. Yeah, someone else said TB. So there is one case reported in the literature that we could find of something vaguely similar where they detected mycoplasma. You can always find a case report for pretty much anything, so we didn't put too much on that, but the fact there's only one case report made it seem pretty unlikely. How do you test for mycoplasma? If you want to prove this radiologist is right or wrong. Serology, yeah. Lymph node AFBs, you can do TB, yeah. Okay, serology, PCR. Okay, what you can do PCR of? The lymph node. Know what you mean? Yeah, okay. So, yeah, so you can do serology and you can do PCR from tissue or from throat swab or an MPA. What is the big caveat for doing mycoplasma serology or finding it in the back of the throat? If you find it, does that give you the diagnosis? Yeah, so asymptomatic carrier status, yeah, all good comments. So excellent Dutch study, or several studies that have shown approximately 1 in 5 children with respiratory symptoms have positive serology for mycoplasma, but also 1 in 5 children with no respiratory symptoms whatsoever also have positive serology for mycoplasma, and it's almost exactly the same numbers for finding using PCR to find the bacteria in the back of the throat. So about 1 in 5, 20% with respiratory symptoms will have it in the back of the throat, and 1 in 5 without respiratory symptoms will also have it. So that makes it extremely difficult to know what that means if you find it in the back of the throat with someone with any sort of symptoms, because the likelihood is you'll find it, or serology rather, is you can probably also find it in children who don't have any symptoms whatsoever. And that also goes for the kids with the sort of encephalitis that we always start on a macrolide and then do serology. So very difficult to know what that means, but you can, they're essentially all you can do for it. And how do we treat mycoplasma? We've touched on this already. So I won't dwell on it too long, but essentially macrolides, you can also use fluoroquinolones like ciprofloxacin, and doxycycline is another choice, not for a 1-year-old really, but sort of teenagers you can potentially use doxycycline. So actually, we never found a cause for this child. He received, I think, ceftriaxone and some amoxicillin for a period of time, and everything sort of resolved by itself. Lots of investigations for TB and other things, but it resolved, and we never really found a diagnosis. But his mycoplasma serology and PCR were both negative, so it almost certainly wasn't that. Okay, so a bit of nice guidance now. See how well you know this. So 1-year-old meningococcal septicemia. How long are you going to give ceftriaxone for? What does nice say? Okay, so a bit of a spread here. 5 days, 14 days, 7 days, 10 days, 14 days, 10 days, 14 days, 7 days. Okay, so nice says 1 week, 7 days. Okay, what if it's meningococcal meningitis and not septicemia? Okay, 14 days, 21 days, 7 days, 14 days, 14, 14, 14, 14, 14 to 22. Okay, and it's 1 week, doesn't make any difference. Okay, what is meningococcal meningitis and septicemia? Double whammy. Any difference? Someone's mentioned about repeating CSF culture, as in, would you, if you proved it was positive and then you would check that it's cleared? So usually for meningococcal meningitis, we don't do that. Often we don't even do an LP if they're really septicemic, because A, it's tricky to do it if they're septicemic, and B, actually it doesn't really change what you're going to do if you know it's group A, meningococcal disease, because even if you've got both, you still only give 1 week. So whether you've got meningitis, septicemia, or a combination of the two, actually NICE says you give 1 week of antibiotics. And clearly, if you get sequelae as a result of it, or nosocomial infection, that might change things. But actually, to treat the bug, you need a week. In fact, there's pretty good evidence from low and middle income countries that you probably only need 1 or 2 doses of antibiotic. But everyone's a bit twitchy, suggesting only giving 1 or 2 doses. So that's why NICE went for a week. So if you know it's meningococcal septicemia or meningococcal disease, 1 week. And note, you don't need any oral antibiotics. 1 week is the full treatment course. Okay, what about pneumococcal meningitis? "14 days, someone said. Any variation on that? Higher, lower? Okay, 10 days. So 2 weeks, days. This is for your standard pneumococcal meningitis. So clearly, if you've got lots of abscesses or empyemas, then it might change. But for standard, quote unquote, you're looking at 2 weeks. Okay, what about a 1-month-old with GBS meningitis? So late onset sepsis, meningitis, GBS, group B strep. Okay, so perfect. Someone's literally just asked, what about group B strep meningitis in the neonate? So great minds think alike. So we've got 14 days, 21 days, 2 weeks, 21 days, 14 days, 21 days, 3 weeks. What about dexamethasone for pneumococcal? Okay, we'll come back to that in a second. So the answer for GBS is, everyone's right, is sort of prevaricates and says somewhere between 14 to 21 days. That's usually we kind of go for 14. If there are suspicions of collections or thromboses or things, then we would extend that out. But NICE says somewhere between 14 and 21 days. So dexamethasone for pneumococcal. So for the older kids, NICE does suggest giving steroid in some circumstances, and I can't remember all of them, but essentially if you have a very high white count, is one of them. If you can do it within the first, I think it's 48 hours, you give it for kind of 4 days. So potentially if you knew, or frank pus is another one, isn't it? If you were highly suspected of it being pneumococcal, then potentially do give steroids. Oh, frozen. Okay, what about E. coli meningitis? What does NICE have to say about that? Okay, so everyone's nailed down for 3 weeks, 21 days. Good, perfect, 21 days. This is the one where people and ah about, do you do an LP at the end to check you've cleared the bug with gram negatives. Some people would advocate that, some wouldn't. It partly depends a bit on how the child is doing, I would suggest. Partly depends a little bit on the bug. So certainly things that like Citrobacter, that are more likely to form abscesses, one might be more inclined to do an LP at the end. Nice, I don't believe, says to repeat an LP at the end of the course of treatment. Standard treatment would be 21 days. Again, clearly if they're not getting better, they've got ongoing fever, there's suspicion about abscesses, then you might want to do that. So it depends a bit on the clinical course. Actually, the other thing to say, in a 1-year-old, E. coli meningitis would be pretty odd. How often do you see E. coli meningitis in a 1-year-old who's otherwise fit and well? Pretty rare. So you might think about underlying conditions. So we certainly had a couple of cases of children who had a pit at the base of their spine that wasn't a pit and actually went all the way through to the spinal cord, who presented with gram-negative meningitis. And so, if it was a tiny baby, neonates, then E. coli meningitis is, relatively speaking, common. But older kids with no underlying medical problem, the gram-negative meningitis, you should start thinking, is there something else going on? Because that's a little bit odd. Okay, hip meningitis. Rare to see that these days in the UK, as everyone's vaccinated pretty much. 10 days, says Kat. Perfect. And this is the one where there's good evidence for giving steroids. Yeah, 10 days. Steroids if you get it in time. Okay, 1-month-old listeria meningitis. How long do you give ceftriaxone for? Ooh, silence. Other people are bored with this game, or they don't know the answer. Okay, very good. Amox, question mark. Amox. Good. So you don't give ceftriaxone because ceftriaxone is no good for listeria. So what you want to give is amoxicillin and with a bit of gentamicin as synergy for probably about a week, although people will pontificate on how long exactly you give that for. And you want to give it for 3 weeks, or the amoxicillin at least for 3 weeks. Very good. Okay, so last handful here. So 2-month-old, 1 day of reduced feeding and fever, done a full septic screen, you started them on Kef and possibly amoxicillin. You get to the CSF back is 1,200 white cells, more than half are polymorphs, but the glucose, protein, lactate all normal. White count and CRP aren't very exciting, and your virology lab very efficiently turns it around in 12 hours or 24 hours, and you get the enterovirus. And it comes back with enterovirus, and at 36 hours, all your other cultures are negative. So blood culture, CSF culture are negative, and the child is much better. Are you happy stopping the antibiotics? And for the person asking about listeria, I haven't seen a case of listeria for years. Very rare. So would anybody, okay, so most people are saying yes, yes, yes. They would be happy to stop antibiotics. Somebody said polymorphs suspicious. If all viral, would expect lymphocytosis in the CSF. Was CSF done before antibiotics? Yes, it was done before antibiotics. The A&E SHO was highly efficient, got it first time. So yes, 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 somebody says ask Macrolides. Okay, so early in enterovirus, you can get a lot of polymorphs. So actually, I'd be perfectly comfortable stopping the antibiotics in this setting. So even with quite a high white cell count, and even with more of it being polymorphs, if you've got a good, you know that the enterovirus is positive, in the context of other cultures and things being negative, and the clinical picture fitting, i.e., normal, lowish, white count CRP, a reasonably well baby who's got better pretty quickly, I would suggest stopping the antibiotics. Clearly, if various caveats are if received antibiotics after before the LP, that might cloud things. Does depend a bit how long. If the clinical picture really didn't fit, that might make you suspicious. I did help write a article on enterovirus meningitis and CNS disease, which kind of covers lots of this and lots of the clinical questions. So I'll point you in that direction if you're really interested. Self-plug there. And then the other thing to say is the white count can be up to several thousand, so 3,000 or 4,000 even in enterovirus meningitis. So the height of the white count in itself, again, at that level, wouldn't particularly worry me. Bearing in mind the other parameters sort of fit with an enterovirus infection. Okay, 2-month-old, 1 day of reduced fever and feeding, had their vaccines in the morning, including the MenB one, which we know half the time gives children a fever. What would you do? Paracetamol. Yeah. Good. So I mean, this is one of those, it's impossible to answer question. People will do anything from the full septic screen, give antibiotics, to a partial septic screen, not give antibiotics and see what the CRP and the white count is, to do nothing and just observe them for a bit. And probably all of those are appropriate in various times. Depends a little bit how the kiddie is, what do they look like. If they had one-off fever and it's got better without doing anything with paracetamol. So there's not really necessarily a right answer for this. There was a nice case report of a child, this was from Oxford when I was there, who had this exact scenario, although they had a seizure, so it made it a little bit more clear cut, who actually turned out to have Men-C meningitis the same day they had their Men-B vaccine. So I mean, that's unlucky to say the least, and they did present with a seizure, so it wasn't just a low-grade fever, but that made everybody a little bit twitchy for a while. But I think any of these is probably reasonable, and it will depend a little bit on what the clinical picture of the baby is. And what have people said on here? A, B, C, D, yeah, perfectly appropriate. Observe plus paracetamol. Admit potentially paracetamol. Safety netting, yeah. So I think all of those are completely appropriate. Somebody asked about prognosis for enterovirus meningitis. Is essentially excellent. If it's just meningitis, then the prognosis for enterovirus meningitis is essentially normal. Almost no kids have any sequelae. Encephalitis is different. Lots of them will have problems. Okay. Neonate, I think a couple more to go. Neonate with sepsis, you get a call from micro saying got gram-positive cocci, and they think it's a strep. And the reason they think it's a strep is because it's one of these top two. It's either in chains or little diplococci in a little couple, rather than staph, which is where you get as much more cluster. So they're reasonably sure it's strep. What bugs could that be? Oh, I've got about 2 minutes left. So group B strep, group B strep, group B strep, group B strep. Yeah. Anything else? What if it was a 10-year-old? Okay. So group B strep obviously is top of the list, but there's a whole list of other streps that it hypothetically could be. So group A strep, puerperal sepsis, is the thing that used to kill babies 100 years ago and mums. Strep viridae group, CDFG strep, strep pneumo. So enterococcus used to be called Streptococcus faecalis and faecium rather than enterococcus. So that's where you can go wrong. If you say it's gram-positive cocci and you've got them on ceftriaxone, you go, hey, we're all sorted, because actually enterococcus, if it turned out an enterococcus, that's not treated by ceftriaxone. Lactococcus even is possible. It's very unusual, but it's not impossible. And then, of course, you've just got somebody looking under a microscope. And whilst I've picked some examples that are really obvious, you can imagine that if you looked at, a couple of the little diplococci, you can't see my marker, can you? If you've got very scanty staph, for example, it might look like the picture in the top right with the pink background. So, it's not that infrequently that somebody says this looks like a strep, but actually it turns out to be a staph, or vice versa, or some other gram-positive cocci, or very occasionally somebody says it's gram-positive and actually it's gram-negative, because the way you can tell is one goes blue and one goes pink, and you can certainly tell probably see on the top two or the top left picture, some of the little blue blobs look a bit pink. So again, you can imagine if there's only a handful of them around, very easy for someone to go, well, I think that's a pink blob, that's a gram negative, rather than it's a blue blob, gram positive. So you've always got to be slightly wary when you get these, when you get the call from micro. You know, the vast majority of the time they will be right, but if the kid's, you know, not doing what you're expecting, you've always got to kind of think again. Is there a group E strep? Good question, and I have to say I don't know the answer to that. I have a feeling it might be Enterococcus, but that I may have just made that up. I'm sorry, I don't know the answer. Okay, I think we're almost running out of time. So 2-week-old with HSV from a sticky eye who's otherwise well, what do you do? The options are nothing, reassure, or B, admit and do full screen and start them on antivirals. Okay, someone's gone for nothing. Anyone want to go for everything? Okay, so the answer is you do the whole whack, which often, and a couple of times as I've done it, as sort of GPs have gone, what, really? The risk is this kid essentially has got skin, eye, mouth disease, and there's a high chance, kind of 50-odd% chance this could progress to encephalitis or disseminated disease. So actually, if you find it in a sticky eye in a tiny baby, you're worried about sort of congenital or neonatal infection. So you do the full whack, you do an LP, you start them on acyclovir. If you don't find it anywhere else, they get treated as skin, eye, mouth disease. That's 14 days of acyclovir. If you find it in the blood or the CSF, they get 3 weeks. Some people would even advocate doing an LP to check you've cleared it at the end. And then they get suppressive therapy for 6 months afterwards because there is a risk of relapse. And then also you might think about getting mum to go to the GU clinic. People have mentioned about ophthalmology, so yeah, you might also get the ophthalmologist to come and have a look. Okay, and then this is the last one. So 14-year-old bronchiectasis Pseudomonas has been detected from some sputum, and they've been on some PIP/TAZ and they're getting better, but don't really, then the respiratory team want to give them 2 weeks of treatment IV. And they ask you, can we switch to ertapenem because it's once a day and it will make OPAT, as in outpatient therapy, meaning they can go home and the nurse can go out and give it, a lot easier. Is that reasonable? Essentially, my question is, does ertapenem treat Pseudomonas? Yay or nay? No. Good. Oh, I've given you the answer there. So the answer is it does not. So it sounds like meropenem, but actually it doesn't have the same activity spectrum as meropenem. So ertapenem doesn't treat Pseudomonas, ceftriaxone doesn't, but the others on there do. So meropenem, PIP/TAZ, ceftazidime, or Cipro would be your go-to antibiotics for this. As we said before, Cipro's got a really good bioavailability. So actually, rather than giving 14 days of IV treatment, potentially you could, you know, switch into oral a bit earlier, which might help things. But ertapenem does not have quite the same activity as spectrum of meropenem. So particularly Pseudomonas is the big one, and Acinetobacter, I think, is the other one. Good. Okay. And then a couple of other questions on the chat about sticky eyes. What's your stance on swabbing neonate sticky eyes in general? Very variable. You know, clearly depend. I mean, I wouldn't just routinely swab a mildly sticky eye because almost every baby has a slightly sticky eye. Certainly if there's conjunctivitis, it's worth doing. If it's persistent, it's probably worth doing. If the kid is unwell, it's worth doing. And the other question was, if the baby's older, will it change management? So if you're out of the neonatal period, then yes, it would do. Because clearly, you know, in a 5-year-old, if you found HSV, you're not going to do a full septic screen. So it's really worried about neonatal. So, you know, beyond about a month or so of life, you wouldn't need to do that anymore. And then someone's asked about, is there neonatal guidance for HSV treatment? are presuming congenital HSV, to which the answer is not that I am aware of. We tend to use the US guidance, which is by David Kimberlin. There's some very clear algorithms for that, of who to test and who to treat. I don't think there is NICE or BPLG or anything specific, but I might be wrong. But okay, I've run a few minutes over, so I'll wrap it up there. Okay, quick literature search suggests Group E strep can only affect pigs. Excellent. What a brilliant way to finish. Thank you very much. I hope you've enjoyed this, and I might do another session at some point. Enjoy the rest of the day. Bye-bye.